CMS Hospital Compare. Initially, we were going over an article that compared New York hospitals and why we fared lower nationally. In doing and reading about the CMS process, I decided to take a deeper look into the CMS Hospital Compare, what it is and why we have it, versus just the single article. CMS, what is it? I'm in the medical field and I really didn't know much about it. It stands for the Content Management Systems. It's commonly known as the Center for Medicare Medicaid Services. The CMS, it oversees programs including Medicare, Medicaid, and their billing. CMS, it collects and analyzes data, produces research reports, and it works to eliminate instances of fraud and abuse within the healthcare system. It's an incredibly large system with many points of data trying to put together, and how they take all that information and compare hospitals. I've seen through reading about it that there are a lot of variables that go into that, which can lead to inappropriate ratings. What does the CMS do? The Center for Medicare and Medicare Services, back in 1965, President Johnson, he signed into law a bill that establishes the Medicare programs. In 1977, the federal government established the Healthcare Financing Administration as part of the Department of Health, Education, and Welfare. Basically, the CMS was basically a data collection service that manages pretty much all of the important national healthcare programs, and does its best to coordinate payments and understanding of basically who's doing what and why. CMS Hospital Compare has a specific rating system. Hospital Compare, it's basically consumer oriented, and it provides information on how well hospitals provide recommended care to the patients. The information can help the patients make informed decisions about where to go for health care. I find that interesting, with insurance companies in recent years directing care and kind of making you go to certain facilities, keeping it in-house or in-network. Star ratings can increase revenue. The higher your rating, the more reimbursement you can get. The CMS star ratings can impact finances. Plus, the increase in enrollment into certain programs can lead to significant revenue boosts. Improving from like a 3-star rating to a 4-star rating, it could increase revenue between 13 and 17%. It focuses and encourages plan members to utilize covered services for healthy patients. It includes annual physicals, preventative screenings, vaccinations, prioritizing the user experience. The star rating system is heavily weighed towards the experience of the plan member. So the carriers really have to show focus on making their services convenient as possible to them. And it is incredibly important to communicate. And that's, I've seen that written a lot on all of the different websites that I've read. In 2002, the federal government first became active in the patient satisfaction end of the Hospital Compare, collaborating with the research development and coming up with these surveys for satisfaction. CMS Hospital Compare. Patient satisfaction is an important and commonly used indicator for measuring quality, the effect and timely, efficient patient-centered delivery of care. Patient satisfaction is the proxy, but very effective indicator. The data on the survey points out congruence between better provider care, patient satisfaction, and reimbursement. Getting back to the CMS's wishes and wants. The 4 critical components that they spoke about to achieve patient satisfaction is to acknowledge them, support them, accept them, and then prepare to act. The acknowledgement, the support, accepting, and then prepare to act. The acknowledgement is quite easy. The support is very difficult. The acceptance is very difficult. And then prepare to act is difficult. When you're looking to support patients, you want to support a system and a patient that is helping itself in the community. It's hard to accept patients that eat salty foods while having congestive heart failure and fail each and every time. And then the prepare to act is directly compacted because the hospitals that are receiving patients, and we're always prepared to act in very difficult circumstances when the clients are not doing their due diligence from a community standpoint. And basically this ASAP acronym we use in the hospital all the time. And acknowledge, support, prepare to act, and accept. We try to do all those things, but that does not stop the negative cycle, which is negative outcomes on patients that have comorbidities, no money, and no support or education. CMS talks a lot about achieving goals, and again, the word satisfaction. The healthcare reform efforts, they emphasize payment as a reward for value. The last slide discussed the reward system and how it is easier to achieve a higher reimbursement when you're dealing with high-functioning patients. It is a recipe for disaster, and it is streamlining payments towards physicians dealing with people with private health care and with private wills and wants to be as healthy as possible. And it goes on to say, while the perspectives has led for incredible advances in medical science, now it be adversely affecting value. Problem-oriented care is clearly one of the drivers of rising costs, and it could be adversely affecting the quality of care depending upon how quality is defined. Reframing the healthcare terms might be something we have to do. We can't assume that health represents the absence of health problems. And that is basically the view of our Western medicine is, there's no health problems, therefore we are healthy. It's a backward modality. Picture having poor general lifestyle and poor general health. You have comorbidities. You have a primary care physician. You have a cardiologist, neurologist, nephrologist. And each of those physicians has to somehow coordinate your care along with you when the patient, again, has a lot of comorbidities, lack of knowledge, poor follow-up capabilities, financial issues, and basic confusion related to plans of care, which is no fault of that patient. As someone who discharges patients all the time, in my 5 minutes, 10 minutes trying to discharge someone, the discharge packet has 4 pages worth of information on it. What information is important, what isn't. I use a highlighter to try to pop information out that is important. And we have a system where nurses have to use highlighters because of all of the legal jargon in a discharge and in a care plan. It is an impossible goal to achieve, to get 5-star ratings across the board, because hospitals have different clientele. When thinking about a patient and areas that have low ratings, there was a big push, and still is a big push, in post-hospital care needs. Medicare spent hundreds of millions of dollars, actually billions of dollars, on extending health care to the community. And with all of this growth and all of this outreach services, one bit of data I found very, very interesting. Basically, the portion of care provided by relatives decreased, and the Medicaid, Medicare services became more of a system of being a support system versus an education system, where the system has to do this, has to provide home care, has to provide hospital beds. And the portion of the paid home care, it increased within 8 months of discharge. And patients were becoming more sedentary at home, and they really weren't getting back into society as we would really hope. When you talk about physicians, they're outworked and outnumbered. There's so much data in reference to how many people physicians have to see, how much work they have to put into each client in a day. And even as a nurse, I always say there's 60 minutes in every hour. How am I going to divide the 6 patients I have and give everybody what they need? Someone's going to need 20 minutes, someone's going to need 4 minutes, someone's going to need another 15 minutes. And you basically have to create an hour and a half to 2 hours worth of work and put it into every hour that you do something. At the same exact time, you have to make sure you have that patient leaving, giving you a 5-star rating. It is virtually impossible. So locally, I work in the ER, and I go to Albany Memorial Hospital. It has a 4-star rating according to the survey. It's a non-teaching hospital. It's incredibly small, as you may know, and it incredibly limits services. As far as neurology, anything, it limits services. Albany Medical Center, as we know, is a regional trauma center. It's really services almost every specialty that we know. It sees patients and it receives patients from literally 250-mile radius. The sickest of the sick come from community hospitals throughout the region, and they all go to Albany Med. Albany Med will see higher fail rates. Albany Med will see a higher instance of overcrowding, patients dying in the operating room because of trauma, because of many different issues. And we are comparing Albany Med to Albany Memorial Hospital. And this CMS website allowed me to do it and showed absolute no data in reference to what does one do versus what does the other do. High volume hospitals with low economic population deal with factors that can't be compared. Poor follow-up due to a multitude of socioeconomic reasons. The patient populations need to provide a better history for physicians and facilities. Thank you very much for a lovely semester, and all the best in the future. Good day.